It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription, or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. Just coming off a 3-day course in Brooklyn Heights in which we taught pain, ultrasound, and much more. I wanted to let you guys know that I revised a virtual pain fellowship. It's on the NRAP Pain website, nrappain.org, or just go to www.virtualpainfellowship.com. And this is the enhanced revised pain exam complete. So basically it's board prep plus anything and everything you need to know for clinical practice to cover pain management, interventions, pharmacological, as well as regenerative medicine and ultrasound. So this is the most comprehensive course I have so far, and it includes a separate new regenerative medicine course. So if you're interested in online regenerative medicine training, it's on this course. And you'll find these at nrappain.org. Pain Exam still has all the board review stuff if that's all you're after. But if you want a virtual fellowship experience or extensive regenerative medicine training for pain docs or docs who practice pain, check out nrappain.org. If you're going to be in Miami in July, say hi to me. I'll be teaching ultrasound as well as hanging out. I have a table in the event space as well. You can meet my staff that will be working there, and they can tell you all about the upcoming ultrasound courses. And the next one is set for July 22nd in New York, and I'm looking forward to it, as well as another one in August, and then San Juan, Puerto Rico. We're doing some training as well, and then regenerative medicine in November. Spaces do fill up, so please sign up early. And as a treat for listening to the podcast, I'm giving you guys early access to the July 4th discount. Just enter JUL423 for 20% off of all board review, online education, in-person workshops at NRAP or Pain Exam. So enjoy that, and I hope to see you at the courses. Today we're going to discuss post-stroke pain or central post-stroke pain, which is a neuropathic pain arising from either acutely or in the chronic phase of a cerebrovascular event. It's a result of a central lesion of the somatosensory tract, and my source is basically a systematic review and meta-analysis to establish the prevalence of central post-stroke pain, describe the characteristics of it, as well as management challenges. They reviewed about 69 papers, and it's fairly recent. It's from 2020. So I'm not going to get into the nitty-gritty of all that. I'm just going to focus on the key points here. Central post-stroke pain affects 11% of those with stroke. More than 50% of patients with a stroke affecting the somatosensory tract will develop central post-stroke pain. More than 50% of patients that develop central post-stroke pain will do so in the first month after the stroke. Clinicians should look for any evidence of central neuropathic pain for at least 12 months after the stroke. And the neuropathic pain can be spontaneous or evoked and may manifest as an extreme response to a painful stimulus like a hyperalgesia, or a painful response to a normally painless stimulus, otherwise known as allodynia. Clinically, the neuropathic pain syndromes are described by a combination of symptoms other than pain, such as tingling, numbness, paresthesias, pins and needles. And they're really classified into two categories: those that arise from damaged peripheral nervous system, and those are a consequence of a central lesion or condition. Central post-stroke pain is defined as a neuropathic pain that arises either acutely or in the chronic phase of a cerebral vascular event, whether it's ischemic or hemorrhagic, and results in the central lesions of the somatosensory tract, as I mentioned before. So to review the pathophysiology and theories as well as plasticity in central post-stroke pain. I have a second reference that describes the network of axonal projections to the different brain regions, and these connections include the ventral and dorsal medullary reticular formation, the dorsal spine nucleus, parabrachial area, the locus coeruleus, and the periaqueductal gray matter. Additionally, the lateral medial thalamus and anterior pretectal nucleus, amygdala, and the hypothalamus are also part of the neural network of pain processing. The ascending path is formed by two parallel pain pathways divided into the medial and lateral systems. The medial system comprises of the spinal hypothalamic and spinal amygdalar, medial spinothalamic, and spinal reticular tracts. It has connections with the limbic, prefrontal, and cingulate cortices. It's also responsible for transmitting information associated with the affective, motivational, and autonomic responses to pain. In contrast, the lateral pathway comprises the spinothalamic tract. The tract transmits information to the lateral thalamus and later to the primary and secondary somatosensory cortex. They're responsible for identifying the nociceptive stimulus quantity, quality, pain, location, and intensity. Although the neuroanatomical connections are known, the mechanisms responsible for the emergence of central post-stroke pain is still unclear, and it is known that they transcend the effect of the structural damage. According to the theory, a central mechanism is a functional imbalance between the excitatory and inhibitory systems in pain pathways that can be related to specific neuronal circuits associated with the neuroanatomical lesions. There has been suggestions based on research mentioned in this article that central pain is due to lateral thalamus hyperexcitability, which is associated with expression of calcium voltage-dependent channels and changes in the GABAergic inhibitory system. Similar results in other animal studies have shown a possible association with development of CPSP, or central post-stroke pain, with increased connections in the affected hemisphere between the medial dorsal nucleus of the thalamus and the amygdala. In another study by Kwan, aberrant neuronal activity in the pathway between the medial thalamus and the cingulate cortex, having the brain-derived neurotropic factor as a mediator, was observed. The author suggests that in this type of thalamocortical dysrhythmia, an imbalance in the activity between GABAergic and glutaminergic systems are involved. So, what are we going to do about this post-stroke pain? What are the treatments? Well, like many neuropathic pains, you have a lot of different pharmacological managements that usually include anticonvulsants and antidepressants. In terms of antidepressants, SSRIs, there was a study that showed that when they used fluvoxamine in 28 patients, that the VAS was reduced after 4 weeks. Interestingly, the subgroup analysis showed that pain improvement was significant only in patients who were treated within the first year from the stroke. In terms of tricyclic antidepressants, there was a double-blind, 3-phase crossover placebo-controlled trial of the pain-relieving effect of amitriptyline and carbamazepine in these patients. There was only 15 patients. And they showed that only amitriptyline produced a statistically significant reduction of pain when compared to placebo. That's level 3 evidence. And then McGowan et al. Just demonstrated the treatment response to amitriptyline in 16 patients because of lateral medullary infarction, and pain resolution was obtained in 2 participants, while the others reported significant reduction. In terms of the anticonvulsants, pregabalin is probably the most tested agent, and the evidence is still somewhat contradictory. Few open-label trials have been done with pregabalin on post-stroke pain, either as a single treatment or as an add-on. In open-label randomized controlled trials, they compared gabapentin and lamotrigine in 30 patients and found that both were equally effective. They have not yet confirmed the effectiveness in reducing pain levels versus placebo. In another study, they evaluated safety, efficacy, tolerability in 219 patients. Although pain reduction at endpoints did not differ significantly between the pregabalin and placebo, there were improvements in secondary outcomes such as sleep, anxiety. So there is some use to pregabalin. Lamotrigine has potential for management of chronic post-stroke pain, but the evidence is based only on small studies. It's level 2 evidence. And they did find reduced pain scores compared to placebo in the studies mentioned here. Gabapentin was effective in management of chronic post-stroke pain in 84 patients with thalamic stroke, and neither levetiracetam or carbamazepine was effective. SNRIs, duloxetine, there was a significant reduction in pain from baseline, but there were adverse events such as nausea, agitation, somnolence, which led to withdrawal of some of the participants. Naloxone, this is IV is of no value in alleviating such pain. I don't have much on the low dose in this study. I'd be interested to find out because I am using a lot of low dose naltrexone. Magnetic stimulation, pretty low risk. They use the repetitive transcranial magnetic stimulation, and the use was studied in a small group, only 25 patients, and it had contradictory results. But there was a great deal of heterogeneity in the studies that were performed with the magnets, and there are different protocols, so it's really hard to say what's what with this. Electrical stimulation of the spinal cord has been used. We all know about spinal cord stimulation. There's motor cortex stimulation. Study in small open-label, non-controlled studies showing satisfactory pain control was preserved for up to 2 years as level 4 evidence. Katayama concluded that responders to the motor cortex stimulation were mostly patients with chronic post-stroke pain in intact corticospinal tract neurons, suggesting that pain control afforded by the motor cortex stimulation requires neuronal circuits that are maintained by those neurons. Kind of makes sense. Also, another study comparing the efficacy of spinal cord stimulation, motor cortex stimulation, and deep brain stimulation. They found satisfactory pain control was obtained more frequently as the stimulation site was moved to higher levels, implying abnormal processing of nociceptive information develops at the level of deafferentation and spreads to higher levels to a varying degree. So that's the whole realm of post-stroke pain that I can find in this short lecture. I really don't see too much of this, actually, in my practice. I would imagine neurologists and inpatient pain physicians are probably seeing a lot more. But it's something to be aware of. It's something to understand and know what tools are available. Leg pain is not always sciatica, right? It could be central pain. So keep that in mind. Thank you and good luck.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.